Actually, yesterday we started slightly different aspect of anesthesia care, and like in a not under different aspect, the most common thing, but in a different way. Okay, so we just discuss some of the aspects of it, and we will just try to continue from there on. Just a starter, a very simple question, which I asked in the to some people in the morning as well. Uh, if you are have giving a perioperative care and urine output starts decreasing, okay, so what may be the causes? Decreased urine output. So anyone wants to speak out? Zishan? Decreased urine output.
Sir.
Walaikum assalam.
The
Yes.
decreased urine output, the considerations could be number one, in the pre-operatively, patient could have a comorbid condition like renal failure, or the patient might be dehydrated. Then intraoperatively, in anesthetic factors, we can see if there are repeated hypotensions or the fluid management is not adequate and the patient is fluid deficient, and or the patient might develop AKI due to either dehydration or the this hypotensive episodes or a low cardiac output state. Then surgical factors, there could be some kind of trauma to the ureters or bladder, and the urine might be leaking into the abdominal cavity other than going into the Foley's, or the ureters could be tied up, and there could be retractors that are stopping the flow of in the ureters or on pressure on the bladder. The patient positioning. Patient could have been head in a head down position in the Tenderberg position, which would cause the urine to accumulate in the dome of the bladder, and then Foley's could be blocked or kinked.
Like whatever you whatever you said, that if we just divide that urine output is decreased, okay, so whatever, like ultimately what there will be hypovolemia, okay, there will be hypotension in the way that the perfusion pressure of the kidneys, which are important for like maintaining the GFR, will be reduced. Okay, so this is like whatever is happening, the end result may be this. Usually the anesthetic factors which will be there will be usually at the end of the day, it will be like that. Okay, otherwise there will be like patient factors, like in which there is a acute kidney injury on top of a chronic renal failure. Okay, so it will result in decreased urine output. So similarly, like there are surgeries in which they are doing aortic clamping. Okay, so at that time urine output can decrease. You are giving hypotensive anesthesia. Okay, so there may be decreased urine output. Okay. Okay, then in addition to that, whatever you told, retraction, ureter problem, Foley's problem. So like this is usually you will be in any patient, you will be looking at the color of the urine. And sorry, so you will be looking at the color of the urine, and then maybe you can give the option will be you can give a fluid challenge. Okay, for that you need to know the fluid status, and you will be doing any correctable thing which you can do, like the basic bottom will be hypovolemia and hypotension, and the perfusion pressures are not maintained for any good reason, or other than that there was that will not be so acute, but because this is just a mind exercise that you have decreased urine output. So what you will be doing, you will be looking at the cause, and then you may be giving some fluid, you may be giving some increasing the blood pressure. And another one of the reason in the patient is, like for example, if patient is taking high dose of vasopressors. Okay, so in one way they are increasing the mean arterial pressure. The mean arterial pressure is a big factor for the maintenance of urine, production of urine. But in the other way, if it is causing so much vasoconstriction, the visceral, so blood flow is decreased, So ultimately this can still decrease the blood pressure. Okay. So, and then as a part of multi-organ failure, which occurs, for example, in sepsis, so it is one of the cause. So you can divide your answer in anesthetic, anesthesia factors. Can you mute, please? Okay. So anesthesia factors, surgical factors, okay, patient factors, or you can divide it into pre-renal, renal, and post-renal, and you can do it as pre-operative, intraoperative, and post-operative. Okay. So in that way, you can divide it like, for example, if the patient has a crush injury, okay, so the crush injury will be causing myoglobinuria, which can cause acute kidney injury. Okay, so this is one of the factors in which there may be renal failure ultimately. Okay, there was a diabetic patient, you gave overdose of NSAID. Okay, so it can cause acute kidney, acute renal failure. Okay, so these are actually additional one. There may be some obstruction, post renal obstruction, and renal, usually it will not be that much acute, but it can happen. Okay, so whenever you are thinking about decreased urine output, you can have troubleshooting in that way. Okay, anything which I missed regarding this?
No, sir, almost everything is covered.
Okay, so what may be the problems related to consciousness? Okay, we actually yesterday we started in a different way. We discuss about some aspects related to respiratory, the basic vitals, the blood pressure, the heart rate, and the temperature. Okay, and we are just trying to see what may be the problems which can occur in the interop. So one of them will be consciousness. Okay, so if there is altered consciousness in perioperative period, what may be the reason? You should be thinking. It may be like it may be in the form of preoperative, when you see the patient and you see there is altered level of consciousness, patient is aggressive or patient is not obeying the commands, or this is one of the thing. Or intraoperatively, of course, if you are going in general anesthesia, so you cannot, so it will be evident as delayed recovery. Okay, so the delayed consciousness, one of the is will be like this. And post-operatively, it may be as, for example, emergence delirium. Okay, so you can think or consider about three things. So now if you just say preoperatively, any cause, like any cause related to
Metabolic
CNS.
abnormality, sepsis.
Sir, metabolic,
CNS.
exactly. Metabolic, drug induced,
Okay,
and any
metabolic,
trauma,
drug. Okay,
and drug,
and
any
any
trauma.
vascular, like cerebrovascular, CNS I have written, but
Yes.
vascular. Okay,
Any
and
respiratory disorder,
yes, any addiction.
hypoxia, any addiction, any drug intake,
Okay,
or any poisoning.
yes, the respiratory cause there
Drugs.
will be there. So you just will be thinking one by one. You will be looking that what, for example, if there is some in MI, even it can occur. So MI,
Yes.
there will be
Syncope and
yes, there will be for syncope. Okay, there may be
yes.
like this one bradycardias, symptomatic bradycardia.
Bradycardia.
There may be altered level of consciousness. Okay, so there will be some associated symptoms. Okay, so it will be
Yes.
cardiovascular. In simple words, if you just want to tabulate, think in your brain, in your mind, it will be cardiovascular associated symptom. Okay, if you have a patient in status asthmaticus, okay, at the end of the day there may be problem in consciousness, so it will be
Hypercarbia.
Yeah, yes.
No,
in this,
in COPD,
Life-threatening-
hypercarbia will be there.
life-threatening SC.
hypercarbia will be there, and actually, if you are
COPD
giving,
and
yes, in
yes,
COPD,
and
if you give-
hypoxia.
yes, no, if you are giving increased oxygen, this may decrease conscious
Yes.
level. Okay,
Yes, yes, yes.
because you have
Oxygen narcosis.
yes, it is called as oxygen narcosis. So you should be thinking
Hmm.
that alter level, and for example, if there is hypo, if you consider about this one metabolic things,
Hypoglycemia. Yes.
hypoglycemia is one of them. Okay, and sodium.
Yes.
Sodium is the culprit.
Sodium. Yes. Hyponatremia.
Both
Yes.
in hyponatremia and even in hypernatremia, it can occur.
Hypernatremia.
Both,
Yes.
but more so in hyponatremia, but it can occur in hypernatremia as well. Okay, so you will be going,
Hyperuricemia.
yes,
Hepatic incaf.
urea, related to urea and ammonia.
Urea. Yes. Urine. Ammonia. Yes.
So it will be presented as encephalopathy.
Yes.
Okay, so what will be in addition to any other thing, what may be the feature in it in encephalopathy? Flapping,
So, constipation hogi, flapping hogi, yes,
flapping, tremors,
and tremors, yes,
okay,
flapping
and of
tremors.
course there will be some precipitating CRF or CLD. Okay,
Yes,
so
CLD.
if you have altered level of consciousness in a patient with CLD or CRF, you will rule out encephalopathy first, and there will be certain signs which will be accompanying it. Of course, whenever you are talking about CNS, you will be looking at actually sensory system,
Yes.
motor system,
Hmm.
okay, and
And
autonomic.
autonomic.
Usually.
system.
So now you can think about
Yes.
it, and you can, and of course the higher mental function. Okay,
Higher mental functions,
higher
yes.
mental functions. So whatever you are looking at, you will be thinking about these 3 or 4 things. Okay, all can occur. And another, this will not be directly related to CNS, but some of the aspects will be there is in spinal cord injury. Okay,
Yes, spinal cord injury.
so in spinal cord injury, the consciousness level may be there, okay, or they will be there. But for example, if it is lower level, so there will be motor. If it is higher level, for example, it is cervical, patient will not be able to.
Autonomic derangements will be there, sir.
Yes, autonomic derangements will be there. Patient will be
Dysfunctions, yes.
apneic, okay, because of
Apneic,
involvement of
yes.
this.
Apneic, bradycardia, arrhythmic,
Yes,
hypotensive,
apneic because
hypertensive,
of diaphragm.
diaphragm, yes.
Yes, diaphragm if it is cervical injury. Okay.
Hmm.
So these are the things which you can consider. So you will be going one by one. If you want to evaluate, for example, the similar patient, if it is, you will be ruling out any CNS cause by the help of some radiological studies. Okay. Metabolic, you can do some ABGs. Okay.
ABGs,
Doing
electrolytes,
electrolytes. You can just
RBS,
urea creatinine. Okay. Blood sugar level. So you will be,
ammonia, blood
and
sugar
then
level,
another
yes.
one thing we missed actually is myxedema coma. Okay, myxedema, the
Yes,
endocrine we did not
yes.
see. Myxedema,
Endocrine, yes.
Addison's crisis. Okay?
Addison's crisis, exactly, yes.
Addison's crisis will be accompanied by hypovolemia, hypotension, okay?
Hyponatremia will be there, right?
Hypoglycemia.
Hmm.
So like there may be some history or some reason, but you have to rule out these.
Sir, hypoproteinemia?
Hypoproteinemia in Addison's disease.
No, sir, in Cushing's or nephrotic syndrome.
It will not be conscious level. We are talking about conscious level. Okay.
Conscious level.
So this may be some. So you will have some so relative investigation for it, but you will be starting like that. Okay. You will be.
Such CSF studies for viral or bacterial or tuberculosis, meningitis, or encephalitis.
Of course. This will be encephalitis.
Yes.
Okay. See, but usually you will be doing some radiological studies and MRI, CT scan. You will be doing like that. Okay. So okay, another for now, if we just discuss about this delayed recovery. Okay. So delayed recovery, what will you be doing? You will be thinking about anesthesia. Okay.
Yes,
Patient is not waking
anesthesia.
up. So
Any neuromuscular disorder.
Neuromuscular disorder, the consciousness. So you will be thinking about opioids overdose,
Yes.
or benzodiazepine, or if, for example, if you have given, it was an obese patient and the surgery was too much prolonged. Okay. So inhalational agents may also be the reason for delayed recovery. So you will be
Non-reversal of the neuromuscular blocking agents, sir.
yes. So so you will be checking the nerve stimulator to see, rule out this thing. Then inhalational, you washed out. If you have MAC, you will be following the MAC. If, for example, MAC has achieved 0.3 and still patient is not waking up, so you will be thinking about it. Okay. For opioids, there will be some pinpoint pupil, and actually there will be some respiratory pattern. Okay. Shallow and low heart, low, like there will be bradypnea and shallow. Okay. Slow and shallow breathing. So usually benzodiazepine, actually, I'm not sure what is the exact sign, but usually if you are ruling out, then you will be considering, for opioid, you will be going the naloxone. Okay. For benzodiazepine, if you have, you will be giving flumazenil.
Flumazenil, yes.
And similarly, if you find anything at the similar time, you will be looking at oxygen, you will be looking at CO2, you will be looking at blood pressure, you will be looking at this one temperature. Okay. Because hypothermia is one of the reasons for delayed recovery.
Yes.
So you will be looking at the vital signs, you will be doing these things, and then if still there is, you can do some ABGs. ABGs will tell you some
RBS.
yes, blood sugar level. Okay. And the same thing that you will be ruling out the thing. Yes, you can consider about dexapram. Okay. So doxapram is a respiratory stimulant. Okay. So you will be trying to give it. So if all these things fail, then you will be praying to God to save you as
Sir,
well.
why to consider doxapram?
Doxapram is respiratory stimulant. Okay. So
Okay.
doxapram, because it's not available in every hospital, but doxapram is there. It is causing, actually it's CNS stimulant. So if nothing is working, so you can try, because usually I have seen one patient, and now you have asked, I have seen one what is that? Just a second. I have seen one patient with propofol. This was a spine surgery case. Okay. And it was lasting for 6 to 7 hours. We gave everything. Still, the patient was not getting up. So we did not find any cause, because that patient had propofol with remifentanil. So actually, there is no reason for that patient. No sevoflurane, nothing. So because of course we had given some other opioid, so we gave naloxone, we gave flumazenil. The patient was not getting up. So maybe there was something related to propofol in that patient. Okay. And we gave doxapram. So because it was a non-specific CNS stimulant, so patient getting up. So I'm just telling you that if nothing is working, you can try. And if even this one is failing, then you will be thinking about some neurological injury. So you will be planning for, first of all, you will be consulting ICU, that maybe the patient may be needing ICU, and then you will be ruling out any CNS cause. So, okay. So this is how you can proceed with a case of delayed recovery. Okay. These words which I have told you, this may be asked in the exam, and this may be asked, actually this may be helping to you in daily practice, that you do one thing, and another practical thing, maybe someone will agree or someone will not agree. If you have given too much ketamine, how can you reverse it? Is there any way to reverse it?
No, sir.
Actually, if nothing is working, you try with naloxone.
Naloxone, yes, naloxone.
Because ketamine has some effects on opioid receptors. So this one actually I have never read about it, but this is my practical experience, that if patient is not getting up by any cause, if you give naloxone, patient will wake up. If there is no other, if you have not done some magic in the brain by your anesthesia, the patient will wake up. But whenever you are giving naloxone, you should be ready for patient coming out up in with severe pain, patient coming out with severe chances of emergence delirium. Okay, and patient may become tachycardic, hypertensive. Okay, so these are the things you should be expecting when you are using even naloxone, even flumazenil. Okay, even with the doxapram. By the way, I myself have seen small sort of epileptic activity. Okay, with doxapram. Okay, so this is a few words about consciousness. So now we will just discuss about some of the arrhythmias. Okay, arrhythmias, and actually for example, if you want to see the cardiovascular problems which will be there, will be in the form of blood pressure, heart rate, rhythm, okay, cardiac output. Okay, usually whatever you are looking at, you will be cardiovascularly, you will be looking at these things. Either there will be tachycardia or bradycardia, there will be hypotension or hypertension, there will be rhythm is not normal. Okay, and there will be signs of low cardiac output. So whenever you are in the operation theater and you find anything, cause may be anything, but the result will be, if you want to see the result will be like that. Okay, so if you just see that if there is some tachyarrhythmia, can you hear me, or there is some
Yes, sir.
yes. So if there is, for
Yes, sir.
example, if you divide it in tachy or brady, this will be one thing, and regular versus irregular. Okay, so if you just classify in this thing two things, and then stable versus unstable. Okay?
Unstable, yes.
So tachycardia may be simple sinus tachycardia. Okay,
Sinus ventricular, yes.
there may be SVT, there may be VT, there may be atrial flutter, there will be atrial fibrillation, there will be
Fibrillation.
atrial fibrillation. Okay, so out of those, the sinus will be regular, SVT will be regular, VT will be, yes. And another way was also broad complex versus narrow complex. Okay, so you can classify further, but the basic concept is like that. Sinus is regular, SVT is regular, VT is usually regular, unless this may be polymorphic or monomorphic. Okay, so monomorphic usually will be regular. Even what about flutter? Flutter is regular or irregular?
So in Flutter also mostly the ventricular rate is normal, regular.
So flutter may also look,
Yes,
whatever
regular.
irregularity is there, but it is looking, but there in the arrhythmias which it has no rhythm is AFib and VFib. Okay, the tachyarrhythmias which has no rhythm actually is AFib and VFib. So the AFib is bizarre. You cannot identify anything. Okay.
Yes.
So one by one, if you just think about sinus tachycardia, so intraoperatively, again, remember one thing: if you want to be accurate in your answer and you don't want to miss anything, again, you always divide into patient factor, surgical factor, and anesthetic factor, and you will find some of the reason. Patient may be maybe high fever, patient may be having fever,
Toxic, hypercapnic.
okay, or
fever.
there may be thyroid reason or any hypermetabolic state. So they will be, because we cannot do everything in detail. I'm just giving a concept. There may be any reason in the patient related to tachycardia. Okay, there may be some surgical stimulation which can cause tachycardia. The number of things will be anesthetic. Like if the patient is hypoxic, there will be tachycardia. If patient is hypercarbic, there will be tachycardia. If there is inadequate
Light anesthesia.
Light plane of anesthesia or analgesia, there will be tachycardia. Okay. If you are giving some wrong medication.
Hypovolemia.
Yes. hypovolemia, there may be tachycardia. Okay, so then you will be clinically correlating it. You will be giving fluid challenge. You will be increasing the depth of anesthesia. You are giving paracetamol, and then gradually you will be correlating it. For example, if there is a tachycardia with CO2 going up, it is some hypermetabolic. So it may you can think about thyroid. You can think about MH. Okay, you can think about NMS. Anything can happen. Okay, so if, for example, CO2 end up the surgical factor, what is surgical factor? Laparoscopic surgery. Okay, if you have a patient undergoing laparoscopic surgery and CO2 going up with tachycardia, so you first thing you have to rule out is maybe patient is not ventilating properly and CO2 is going high. So you will be looking at this cause. Okay, so on top of it, or every patient, at any time, if patient become unstable with blood pressure, that will be something. And usually in majority of the patients in any arrhythmia, in this hypotension occurs, actually you are going towards cardioversion. Okay, if the patient become hemodynamically unstable, whether it is SVT, whether it is VT, whether it is AFib, whether it is a flutter, you have to do synchronized
Cardioversion. Sir, in VT only in monomorphic will do synchronized, right?
Of course.
Polymorphic.
Yes. In polymorphic, you will do pacing.
No, sir. Defibrillation.
Pacing. Polymorphic VT. What is that one? Torsades.
It's
Okay. Defib is for VFib.
yes, sir. But I also remember, Jenny. I'll look into it.
You confirm it. Okay. Polymorphic VT. You have to give magnesium because this is torsades usually, and you can give, and the other answer is pacing. Okay, so in this page the JOs will be different, but in any patient who became hemodynamically unstable in the form of low blood pressure and conscious level decretion, patient is sweating. Okay, so you will be, and this is SVT, because in SVT there will be no P wave. Okay.
Yes.
No P wave with regular rhythm.
Regular rhythm and high.
Regular rhythm and heart rate is more. Okay. So some people concentrate on the rate. Okay. So actually the thing, rate, if, for example, perioperative period, you are doing a case, you see, you cannot be 100% sure. Okay. But if you see the rate going too high and you are not able to identify any P wave, you have to, even if SVT you can occur at rate of 160. Can it occur or no?
Yes.
Yeah, it can occur. Okay, it can occur at a low rate as well. And for example, if the rhythms are irregular, the heart rate you cannot rely unless you get a 12 lead ECG. Even in that, you cannot rely on the rate. So don't waste your time in checking how much is the rate. You have to see the rhythm, you have to see the hemodynamic instability, and you have to, at least in the exam, you have to answer like that, because in that way you cannot rely on the rate. Okay, because you may not be able to get the clear rate. Okay, so atrial fibrillation or atrial flutter, there are certain things you will be doing. In unstable, you will be doing like that, and in stable, a little bit different. For SVT, you will be doing vagal maneuvers. Okay, vagal maneuver may be cold ice or carotid massage and Valsalva.
Sir, vagal maneuvers do work under anesthesia also?
Yes.
Yes.
You will do carotid sinus massage. You can increase the airway pressures. Okay.
Sir, how does cold ice packing work?
Very good question.
Actually, I
Cold ice
haven't
packing?
done.
I don't
I
have
haven't
the
done
answer.
it.
I have not.
Okay.
I don't have
Sir,
the answer. This is just repetition.
Actually,
of
only the cold
ACLS.
water is given to the patient, like in the normal conscious patient, the cold
No.
water is given
If you
instead
go
of
do the
Valsalva.
ACLS, if you do the ACLS, some remember one thing, whatever I am telling you, for the answer in arrhythmias, answer is ACLS. Okay, you have to
Okay.
follow the ACLS. So I think this is causing vagal stimulation. Okay, here also vagal stimulation. Here also vagal stimulation.
Cold icing of the whole body.
No, cold
No,
ice
no.
pack on the forehead.
Okay.
Okay. You open the book of ACLS, you will find it.
I've recently read it, sir. I didn't find it there.
No,
That
it is there.
read-
It is there. It is there.
Right.
Vagal maneuvers are cold ice packing on the forehead, Valsalva, and carotid massage. Okay.
Okay.
And then VT. VT may be actually three categories. VT may be stable. VT may be unstable. And VT may be
Pulseless.
Okay. So if it is pulseless, it is with VFib. It is friend of VFib. I don't know why they are categorizing separately. They should set it anyways, but the rhythm will be regular. Rhythm will be, there will be no rhythm actually in ventricular fibrillation. Okay. Okay.
Yes.
So like in stable VT, what will be the answer for stable VT? The stable VT answer will be lidocaine.
Lidocaine first, then
Lidocaine, yes. Dynamite.
Okay.
Yes.
And treating the in all everything, your answer will be ABC. Call for help. Okay. Evaluation, resuscitation, and management will go side by side. Treat the cause. Okay. Treat the cause. Look for any reversible things. Okay. The reversible thing is always oxygen, CO2, pain, volume. Okay. Even tube, endotracheal tube touching the carina. Okay. This may also cause arrhythmias. CVP, you have a CVP.
Yes.
This is in the heart.
Charging has finished. Just give me a second, please. I think my stillet is dead now. So let me see the other stillet will work or not. Okay, so tube, I will just try to tube touching the carina.
You were talking about CVP, sir.
Yes, CVP. So CVP, how can it cause arrhythmias?
If you placed it inside, yes.
Yes, so if it is touching the RV,
touching the right atrium.
Right ventricle. Okay, right ventricle.
Right atrium. Yes.
Even atria, it is touching the wall. Okay.
Yes.
Touching the wall, it can cause arrhythmias. Okay. So you can find so many reasons for it. Think about, try to make a list of reversible things which can cause instability in your patient. Okay. Even you will find a number of reasons for it. So this is one of it. And then what arrhythmia VT is unstable. Yes, in unstable VT you will be doing the cardioversion. Okay.
Cardioversion, yes.
Cardioversion, synchronized cardioversion, and the next question they ask is which thing you synchronize R waves. And if you do
RR waves, yes.
Yes, and if you do it in T waves, it will cause ventricular fibrillation. Okay.
Yes.
And whenever you are telling defibrillation, you should be knowing that defibrillator itself can cause a lot of problems. It can cause burn, It can cause, it
Violence,
itself
yes.
can cause arrhythmias. Okay. And the people around can be electrocution with the patient. Okay. You can give shock to people around you. If patient is not clear and you are touching it, even you yourself can be getting a shock. Okay.
Yes.
So these are the things we should be knowing. Then some extra thing, how much is the pedal size, how you should place it. You should be knowing about it. Okay. And reversible causes of arrhythmias, also ABGs. Okay. There may be some electrolyte imbalance related to potassium, calcium, magnesium. Okay. So these all are causes of reversible causes of arrhythmias. Okay. Hypoxia is cause. CO2 narcosis is cause. Okay. So you will be targeting. Now, for example, atrial fibrillation or flutter. Okay. Atrial fibrillation or flutter, actually, the things which you should be knowing is that you have to rule out it. The duration, how much duration has gone is important. And there will be things related to the stasis of blood. Okay. So there will be chamber clot. Okay. So in that case, you need anticoagulation.
Yes.
Okay. Because it can cause result will be CVA.
CVA, yes.
It will be going from the aorta.
Carotid to the
Yes.
cerebral
So,
artery.
there can be ischemia. And there will be
Ischemia.
stroke. So you have to do the anticoagulation, and then you have to control the rate, and you have to control the rhythm.
Rhythm.
So for rate control, they can give beta blocker. Okay.
Beta blocker.
And for rhythm control,
Amiodarone.
amiodarone. Okay. And another medication which they use is digoxin.
Digoxin, yes.
Okay. And if it becomes unstable, you will do the DC cardioversion. So
Cardioversion, yes.
and that will be the theory for it. Amiodarone is actually used in VT as well. Okay. Even in stable VT, they are giving it. Okay. So
Digoxin isn't digoxin not included in the ACLS these days?
it is included. Reconfirm it, or I think it is included. You have to do the rate control and rhythm control. Just reconfirm it. Okay.
Right.
Maybe it is not there, but confirm it. But actually, if you read the articles for atrial fibrillation, you will definitely find digoxin. Okay. So for digoxin, they can ask you that digoxin has narrow therapeutic index. This patient can have digitalis toxicity. And what are the ECG? I don't remember the ECG changes. You should be knowing the ECG changes in digoxin toxicity. And digoxin toxicity will be occurring if there is hypokalemia. Okay. So this is also MCQ question. Digoxin toxicity will occur in hypokalemia. And when digoxin toxicity occurs, it results in hyperkalemia. So this is an MCQ which I know since many years.
Hyperkalemia.
I'm not be able to explain to you in detail what is the reason for it, but you should. This is I know about it, that hypokalemia will precipitate digoxin toxicity, and when digoxin toxicity occurs, it will result in hyperkalemia. Okay, so they can ask you for any medication. You should be knowing what is the genre. Okay, what is the generic of that medication, like what kabila, what caste is it, then what is the mechanism of action, and what is anesthesia relevance. Okay. What is anesthesia relevance, any specific drug interaction. Okay. And then systemic effects mainly related to your systems, CVS, respiration. Okay. So you should be knowing that liver, because you are dealing with these 4 systems usually. Okay. And CNS. So if you know it, any medication which you are being asked, try to read it in that way rather than cramming the pages and pages or pages of your holy book. I will not name it. Okay. But you all know which book I am talking about, because I have divorced that book many years ago. So I have don't have good relationship with that now. Okay, so so you should be knowing about this thing. Then anything I missed in arrhythmias? Usually if these things fail, the other options are pacing. Okay, and tachyarrhythmias on tachyarrhythmias only this one, actually this one which I told you, polymorphic VT. For bradyarrhythmias, okay, what is the thing on which you decide the whether it is sinus bradycardia or it is PR interval? Okay, so you are looking at the PR intervals, and then you are thinking about blocks. Okay, first degree, second degree, Venki bag. These are actually MCQs question. Practically, it is very difficult to diagnose in the rhythm strip as in the normal ECG. Okay, because in the exam which they are giving you is the rhythm strip, so you will only be able to identify it in proper rhythm strip. Otherwise, in the normal ECG which you see sometimes, unless you are very expert, you may not be able to identify it. But in the exam, right, this first degree heart block, second degree heart block, it is usually it's a very self-explanatory that if it is duration is only prolonging, this is first degree, and then duration is gradually prolonging, it is Venki-Beck. And then if it is
Gradually prolonging.
sorry,
Type 1.
gradually prolonging PR interval and then one is missed. What is that one? This is Venki-Beck.
Second degree type 1, yes, sir.
Okay, and the other one is the type 2 is there is specific pattern 2 into 1 or okay,
2:1. Yes.
okay. So actually, I have missed one of the most important arrhythmia and nobody have mentioned it. What is the most common arrhythmia which any anesthetist see in the OR?
Pvcs.
Yes, you see, I have forgotten and none of you have. So PVC is one of the most, which may be a tip of iceberg. PVC can occur in
Yes.
any patient normally.
Hmm.
And it may be a precursor of ischemia. It may be a precursor
Yes.
of any serious problem in waiting for you. So whenever there are PVCs and they are significant in one, for example, in 1 minute, if it is more than 5 to 6 PVCs, elective case, you should be canceling it and you should be ruling out the cause. Okay. But in intraoperatively, in not undiagnosed patient, it occurs. The same approach which we have discussed, you will be doing it. Airway breathing, circulation, check the endotracheal tube position, check the bilateral ventilation, check hypoxia, hypercarbia, acidosis, and then gradually you will be approaching it. Okay. So this is the, I don't think that you can understand, say it is the most simple way to understand the arrhythmias. Okay. Because if you go in details, maybe you will not be able to understand anything. To first of all, make this basic concept, which everyone should be knowing. And after that, of course, you should be knowing more details than what I'm telling you. But this is the door opening, and then you can read about the exact mechanism, which I told you, like digoxin, amiodarone, all this what we say, class 1A, class 1B. I'm never able to recall them. Okay, but in MCQs they ask, so you should be knowing about it. But the basic concept you should be knowing. Okay, so bradycardias, symptomatic bradycardias, what are the options you have? Atropine. Okay, what else?
Pacing.
Adrenaline, dopamine, pacing.
Adrenaline is not there in first. You repeat the dose up to 3 milligrams.
Atropine, yes.
Should be knowing exactly
Dopamine
what
is
is
now
written in.
included.
Dopamine is not included, yes, until the
Not in the first. So in the
The
second
first is
line,
atropine.
dopamine
Second line is
in the second way, and dopamine, adrenaline, isoprenaline.
dobutamine and isoprenaline.
Not
Yes.
dobutamine.
No. Dobutamine
No.
is not there.
Dobutamine is not there. Okay. So these
Okay.
three
Okay.
medications are there in second, and pacing. Okay. So
Okay.
pacing will be temporary, transcutaneous, transvenous, and then permanent. Okay. So there is a specific, I had discussed pacemakers in detail. If you want to look at it, you can find it in the CVS playlist. You will find, and actually pacemaker, there can be a station specific for pacemaker. Okay, that what are the concerns, how to diagnose. You can have a look. Anyone wants to look at it, it is there in the CVS playlist. You will find. I have discussed in detail. This is just an overview, and I'm just trying to. Okay, and then the other is the cardiac arrest. Okay, so you have to follow the ACLS protocol. I cannot recall everything.
ACLS.
First minute you have to do this, second minute you have to do this, third minute you always do it, but always forget it. With the shockable rhythm, usually what will be the main will be shockable and non-shockable. Okay, this is the first thing you should be knowing. And then you will, just a second, please. Whose mic is? Okay, shockable, non-shockable. Shockable is VFib and pulseless VT. Okay, VFib and pulseless VT. Okay, and non-shockable is asystole.
All others.
And remember one thing: the most dangerous cardiac arrest for anesthetist is pulseless electrical activity. Okay, so remember one thing: there will be a rhythm coming on the monitor, and if the BP cuff is set for 5 minutes, maybe it will be working, and you will be looking at a blood pressure reading, and pulse oximeter, you may be thinking that it is not reading correctly, and the patient may be in PEA. So remember that for that thing, you have hundreds of monitors. The thing which you can never replace is physically touch the patient.
101 more. Yes.
So this is a message for all residents, everyone. Don't forget to touch your patient every now and then. Even if you have limited access, you should have some way to touch the patient in after some time. Okay, because no monitor can replace the information which you can get from the physical touch. Okay, so this is a message for everyone. Like, you, as much as you will become senior and as much as you will become experienced, you are prone to do this mistake. The juniors who are afraid of everything, they will be checking the pulse more frequently than a senior anesthetist. So this is a nightmare for any anesthetist. Okay, so PEA, and for that one, usually you are only repeating 3 to 5 minutes adrenaline. You are not doing anything, and you should be knowing the 5 H's and 5 T's. Okay, for shockable rhythm, you have to check the rhythm after every 2 minutes. Okay, and you are only checking the rhythm after 2 minutes, not after the shock immediately. After the shock, you have to resume the CPR. Okay, so if you see the patient in shockable rhythm, you have to shock it, and then you have to repeat the CPR, and then you have to repeat the shocks every 3 to 5 minutes. And after first shock, you will be giving epinephrine. After second shock, you are giving epinephrine. Pardon me if I forget, because this every time we forget it. Because practically speaking, sometimes we are not following the exact algorithm, but in the exam point of view, you should be knowing the exactly. After second shock, I think epinephrine, and after third shock, there is amiodarone. Okay, this is for shockable rhythms. In other, in pulseless VT, or sorry, this one asystole or PEA, you are only doing the 5 H's and 5 T's. You are correcting you are giving fluid. You are correcting any acid-base abnormality. You may consider to give calcium chloride. You are considered to give bicarb. And then important thing is that because in I think 2020 they have added one thing, which is CPR coach. So CPR coach is something new in ACLS. So CPR coach is the one who is actually supervising, making sure the team leaders orders are being carried out properly. Like if the chest compression is not good, CPR coach is telling to improve the quality of chest compression. if ventilation is not good, chest rise is not good, he is the one to tell that chest rise is not good, things like that. Okay, so this is one thing which was added in, I think 2020, and they can, for the people who are going for oral exam, especially in the OSCE, they can ask you. It's least likely to be asked in the table viva or long case, but it is a station for OSCE, the people who have talks. Okay, especially you people, Zishan and company. Okay, the MCPS people who are going for the exam. So this is one of it. If I miss anything, you can just have a look, because you should be knowing exactly. You have to just, even if you don't make any sense, you have to tell what is written in the ACLS. When they are asking you something, you have to follow the ACLS. Okay. So whatever first choice, second choice, third choice is there, first minute, second time, third time, whatever they have written, you have to exactly reproduce like that. You cannot say anything from your bill. Okay. So I think we will stop here, and we will, if anyone wants to ask any question, just tell. Okay. So thanks a lot.
Tomorrow, would we
Tomorrow,
be
inshallah,
doing the 7 o'clock session or only the 9 o'clock session? 10 o'clock?
Zishan, it will be, I will try to have a look.
Sir,
But
we can do that stuff in this session also.
yes, we can do. I
A
actually
rapid review
I
for
will
one system per day.
I will try to do it tomorrow, inshallah. Okay.
Sure.
And but you can continue keep on discussing the scenarios with me on the group whenever you want. Okay.
Yes, sir. So
Okay.
tomorrow can we do neuro or general surgery or ortho?
Okay,
Anything?
in the we will discuss in the group. Okay, so we will continue our discussion of critical incidents in operation theater, in perioperative period, in ICU from here. Okay, thank you very much. You can find the recordings on the YouTube, so you can have a look on it. Any questions? Anyone wants to ask any question? He or she is welcome to ask through to me on WhatsApp. Okay, thank you. Bye bye.